proceed.
Wonderful. Good afternoon, everyone. Great to see everyone. We will call the meeting to order for the quarterly statewide substance use response working group. I will share that our chair, Attorney General Ford, is not able to be with us today. So I, as vice chair, will be chairing the meeting. And I wanted to mention that at 3:25, I will have to sign off. And at that time, I will then turn over the meeting to Jessica Johnson to chair for the remainder of the time of the meeting. So I just wanted to put that out there. Our first order on the agenda is the roll call to establish quorum. So Kelly, I will turn it back to you.
Crystal Dorsey for the record. Chelsea Cheatham.
Here.
Dr. Dixon.
Here.
Senator Doniate. Excused. Dorothy Edwards.
Here.
Attorney General Ford. Assemblymember Golding.
Here.
Assemblymember Gray. Excused. Dr. Shayla Holmes.
Present.
Jeffrey Iverson.
Thank you. I appreciate what you're doing.
Jessica Johnson.
Please, yeah.
Present. Nancy Lindler. Debbie Nadler.
Here.
Debbie Nadler said she's here.
Angela Nichols.
Present.
Christine Payson.
Present.
Heather, if you can hear me, Heather Goulding, if you can hear me, can you throw your thumb up? I can't hear
Assemblymember
anybody.
Gray, we can hear you. Assemblymember Gray, we can hear you. I'm going to continue with the roll and I'll go back. Eric Schoen.
Present.
Steve Shell.
Here.
Dr. Slamowitz.
Present.
Senator Jeff Stone. Okay, excused. I'm going to go back through. I do believe we have Assemblymember Gray. Can you indicate if you are present?
Use the chat for tech issues.
Yeah.
Well, we do.
Well,
on
we
the
do
floor.
have a floor on the floor. So Vice Chair Shell, I will turn it over to you. We have 12 members present. Our members serving in the Nevada State Legislature through the 2025 session are removed from quorum requirements for the duration of the session and are excused. However, we do have a few here today with us.
Okay, great. Thank you so much. I'm glad that we've established quorum. So moving on in our agenda, item number 2 is public comment. Please bear with me as I make a brief statement. Public comment will be received in person at either of the locations listed above and via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. And before we proceed, I see that I have Deb Nadler, one of our committee members, hands raised. So Deb, I'll turn it over to you quickly.
I have a public comment. So if somebody was before me, go ahead. Somebody else.
Okay. Thank you, Deb. We'll get right back to you. On that note, I'll turn it back to Kelly to give us some other housekeeping details about public comment and then identify anyone wishing to make public comment.
So I think I just want to go to the slide. There we go. Okay, thank you, Kelly Marshall, for the record. So just if you are dialing in from a telephone, please dial 719-359-4580. And when prompted, enter the webinar ID, which is 8411615686. And the meeting passcode is 676835. Please press *6 so the host can prompt you to unmute. And if you are here virtually, you can go ahead and use the raise hand feature to indicate that you would like to provide public comment. Mr. Chair, I see that Quinny Winbush, excuse me, from the Empowered Project has public comment, followed by Debbie Nadler.
Thank you, Kelly. I'll turn it over to Ms. Winbush. Ms. Winbush, can you hear us? We can't hear you.
Can you hear me now?
Yes, thank you.
Yeah, I'm sorry. I wasn't trying to do a public announcement. I was trying to text in the chat saying that I don't know if you can see that I'm here because I wasn't mentioned in the roll call. That's it. I'm sorry. I wasn't trying to make any other comment.
Okay, thank you, Ms. Winbush. Next,
Ms.
I'll turn it back to
Winbush.
Debbie Nadler. Oh, go ahead.
I'm so sorry, Terry Kearns for the record. Ms. Winbush, this is the SURG, the Statewide Substance Use Response Working Group, not the Advisory Committee for a Resilient Nevada.
That's why, but they sent me the link, so, okay, I'm gonna get off then. Thank you.
Thank you.
You're welcome.
Right.
You're welcome to stay and listen.
No, it's okay. You guys have a beautiful day, okay? I'll see you.
You too. Thank you.
Okay, bye-bye.
And now next, I'll turn it over to Debbie Nadler.
Thank you. I don't know if you can hear me. My Zoom screen is really small.
We can hear you, Debbie. Yes.
Thank you. Thank you. First off, I just want to start by saying, I appreciate each and every one of you. Y'all have been wonderful. Been a long road for us. And I'm speaking not as a committee person right now. I'm speaking as a victim's mom from this epidemic. So I'm also speaking on behalf of a lot of bereaved parents here in this city. I know I've said this before numerous times, but there's something missing from everything we're doing. And that is help for the family members who've lost their loved ones and the recognition of our loved ones. Our children were not numbers. But whenever I open the news, whenever I see everything that we're doing, our kids are numbers. Our kids were humans. They had faces, they had lives, they had hearts, they had love. Every year, I have to pay for a memorial. I have to pay for something. Some of this, we sued part of our lawsuit, which we wouldn't even have the lawsuit. If it weren't for our children that we've all lost or our loved ones, it's so unfair that it's the grieving family members here who are paying to make a difference, to help other parents not walk in our shoes. We have to have our own grieving committees. I'm paying over $300 a month to see a shrink. I had to cancel it. I can't afford it anymore. I was denied disability because I can say the alphabet and because I look normal, but my brain doesn't function right. I don't sleep at night. I haven't for 5 years, but it's not just me. I'm just telling you how I'm feeling. Everybody else is feeling that way. We've got moms whose second children are now addicted, the domino effect. We've got moms who are raising their grandchildren. We have to have something, and leave me out. I don't want anything. I want it for everybody else, but it's missing. It's missing from this whole lawsuit, and I'm sorry. It's just I'm sorry, it's my son's anniversary coming up too. And it's just really when I read the reports across the country on where all the lawsuit money has gone, and I keep seeing it, it's so upsetting to see that my child and all the ones we've lost are numbers. That's all they are, is numbers. Please humanize human and because it's not. I wouldn't wish this on anybody, and I'm sorry that's probably 3 minutes.
Ms. Nadler, thank you so much for making your public comment, or speaking during this public comment period. I really appreciate your heartfelt comments. So thank you. Kelly, do we have anyone else wishing to make public comment?
Kelly Marshall for the record. Yes, we have Giuseppe Mandel in Southern Nevada.
Okay, yes, I'll turn it over to Mr. Mandel.
Giuseppe Mandel with Optima Healing and Recovery. Thank you guys all for allowing me to be here. I look forward to learning a lot from you. And Ms. Nadler, I feel your pain. So if you reach out to me offline, and we would gladly help accommodate some of the patients, and we never let price get in the way of grieving families. So reach out to me offline, and I'm sure we'll work something out. Thank you.
Thank you, Mr. Mandel. I think that
Mr.
now
Chair,
concludes.
I don't see any other public comment.
Okay, that concludes that agenda item. We will move on to item number 3 on our agenda. This is a review and approval of our minutes from our January 13th, 2025 SURG meeting. Hopefully all of our members have had a chance to review the minutes. And if so, we can entertain a motion to approve.
Debbie Nadler, motion to approve the minutes.
Thank you, Debbie. Do we have a second?
This is Shayla Holmes. I'll second.
Thank you, Shayla. Do we have any discussion regarding the minutes? Hearing none, all those in favor of approving the minutes, please say aye.
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 Any opposed? Motion carries unanimously. Thank you. Just to also note for the record, we're going to move just a couple of items around on our agenda today. So we're going to jump ahead to item number 8 on our agenda, and then we'll come back to the previous items. We'll ensure that we hit all of our items before the meeting concludes today. Item number 8 is an update from Dr. Terry Kearns. She is going to give an update on Assembly Bill 19. So I will turn it over to Dr. Kearns. Hello, Dr. Kearns.
Thank you, Vice Chair Shell. Terry Kearns for the record. I just wanted to highlight, as you all remember, the Attorney General's office put the BDR, which is now Assembly Bill 19, to increase the membership of the SURG. And the original request was to have a member of the general public, someone from fire EMS, someone from the Division of Child and Family Services or foster kinship, someone from the state public defenders or DIVS, which is the Department of Indigent Defense Services, and a prosecutor from the Nevada District Attorneys Association. It has gone to a couple of committees, and in those committees, there was a recommendation to have someone from DPBH, Department of Public and Behavioral Health, from DHHS on the committee, to have someone who is from a bilingual household that has been affected by substance use, and then also from the Clark County Public Defender's Office. The Chief of Staff has reached out and spoken with some of the various people who had these suggestions. And the thought was that the Clark County Public Defenders should probably reach out to Clark County and give input on their use of the substance use dollars they have. And then that I know that our Chief of Staff was going to talk to the Director's Office from DHHS, because it would end up being 3 members from DHHS. Someone, we have Dr. Slamowitz, who's on the call with us today, who's the director's appointee. We will have someone from Child and Family Services, and then someone from DPBH. So I think that they were gonna come to an agreement, so it would probably be 2 instead of all 3. And then as a member of the general public, give priority to someone who's from a bilingual household that has been affected by substance use. And those were the additions that were made. It has been accepted and made it out of the committees with no amendments to that. So I just wanted to highlight that's where we're at. And I also wanted to highlight that one of the committee members had concerns about increasing the size of the SURG, because sometimes the more people you have, the harder it is to get things done. But we did lay out the way that we have our subcommittees and that we went through our requirements from the legislation that created the SURG. And in that legislation, we took their items A through Q, which are what we're tasked to look at, and split those out among the subcommittees so that each subcommittee is working on different things, albeit there are a couple that are overlapping, and then looking at the special populations. So I think that really kind of put aside his fears of it being too large. So that's my report for Assembly Bill 19.
Great. Thank you so much, Dr. Kearns. Any questions for Dr. Kearns? Okay, thank you again, Dr. Kearns. Jumping ahead, we will move to item number 11 on our agenda, which is subcommittee updates. We are going to have our subcommittee chairs review guidance from their members from their March subcommittee meetings on how their subcommittees will approach developing new recommendations for this year. So I will turn it over to Jessica Johnson with our first subcommittee update.
Thank you, Vice Chair. Jessica Johnson for the record. Good afternoon, everyone. The Prevention Subcommittee met on March 5th. We reviewed our previous recommendations, did a reorientation to the subcommittee and all of the requirements of AB 374 just to ensure we were grounded in the work ahead. I personally really appreciated SEI staff had prepared a crosswalk of the focus populations, both of the prevention subcommittee and the cross-cutting efforts to help us identify maybe some additional areas for emphasis in 2025. The committee did discuss planning and how we plan to approach priorities for this year. We discussed the option to continue to refine and perhaps track across this legislative session any successes related to existing priorities, update as appropriate, and then also continue to identify new priorities. Much of what was discussed as ideas for that meeting were either items that we hope to move to upcoming meetings, such as a presentation on cannabis and cannabis prevention, which would be refining a priority from the 2024 prevention subcommittee, and some of the presentations today, such as the compassionate overdose response and the ACRN presentation of the findings in the report. So I'm really grateful to the SEI staff for prioritizing those on today's agenda. I think that concludes my update from the prevention subcommittee. I'd be happy to take any questions. Thank you.
Any questions for Jessica Johnson? Okay, thank you, Jessica, for that update. Next, I will turn it over to Dr. Kearns for her subcommittee update.
Sure, thank you, Chair. Terry Kearns for the record. The Surge Response Subcommittee met on May 4th. And in that meeting, we did pretty much the same as what the Prevention Subcommittee did, reviewed our policies, legislative mandates assigned to the Response Subcommittee, including special populations, and then looked at plans for the upcoming year. We also reviewed all of the items that were prepared by SEI, which looked at our previous recommendations and our mandates that we were supposed to look at and the special populations that we were addressing, as well as all of the surges. And that was very helpful. And as a committee, what we decided is we felt like we needed more information. We really wanted to determine the results of our previous recommendations So one is waiting to find out what happens in the legislative process this year, and then also looking back at prior ones. So we really didn't come to a conclusion on whether we wanted to come up with new ones yet until we know the results from our prior recommendations. So that was the, and I'm sorry, I also talked about presentations, which some are on here today. We looked at interdiction of drugs, compassionate overdose response, and then we also wanted the Clark County Regional Opioid Task Force review, current trends in substance use, MOUD, medication-assisted treatment in rural jails, updates on Crisis Response Center in Washoe and Clark, and then updates from DHHS on the status and progress of recommendations, and our usual legislative updates and the opioid settlement. And that's our report out.
Thank you, Dr. Kearns. Do we have any questions for Dr. Kearns? Okay, thank you again,
this is
Dr. Kearns, for that update.
Sorry.
Oh, I think we have a question.
Jessica Johnson for the record. Dr. Kearns, I think when you reported, you might have said May 4th.
Oh.
Just confirming you meant March 4th.
I'm sorry, March 4th. Yes, thank you for that, catching that.
No problem. Not really a question.
Awesome. Thank you again, Dr. Kearns. And then our third and final subcommittee update is from treatment and recovery. I will give just a very brief update. I really wanted to echo what Dr. Kearns just shared. Our treatment and recovery subcommittee really was most interested in going back and looking at our previous recommendations and seeing what progress has been made. And so we're looking, and we've asked for some additional information regarding our previous recommendations before we make decisions on what we really want to recommend for this year. So that's where things stand at the moment for treatment and recovery. Not to put her on the spot, I don't know if Dr. Dixon or any of our other subcommittee members would like to add anything to that in case I've missed anything, but I think that was mainly the highlight from our last meeting.
No, I don't think so.
Okay. Thank you, Dr. Dixon. Do we have any questions for the treatment and recovery subcommittee? Okay, hearing none, that will conclude item number 11. We're going to jump out of sequence just one more time, jumping ahead to item number 13, which is a review and consideration of items for our next meeting. And Kelly, I'll turn it back to you. Do you have any items that we previously discussed that we need to bring up today for consideration?
Kelly Marshall for the record. So if we can go to the next slide. So this is just a recap of what we have proposed, and we're interested in any feedback from the SURG committee members. So as is typical during a legislative session year, we expect to do a legislative session recap in July, as well as a presentation from the Division of Public and Behavioral Health on their strategic plan. Two presentations that we believe go together that have been requested previously would be to have the Clark County Regional Opioid Task Force give a presentation, as well as bundling that with current trends in substance use. And then finally, medication for opioid use disorder in rural jails project update. And then separate from those, an update on crisis response centers in Washoe and Clark County to get a lay of the land of what the status of crisis response centers are as of July. So that's the July slate. For October, we would expect presentations on updates from the Department of Health and Human Services. And typically in October is when each of the subcommittees will come with their recommendations and present on them for review and feedback of the full SURG. And then just a reminder that finalizing of recommendations will happen by December of 2025, with the idea that any last revisions will be reviewed, finalized, and approved along with the annual report in January of 2026. In addition to those topics by calendared SURG meetings The opioid settlement updates will be provided at each meeting as available. So I'd be happy to answer any questions or field any suggestions from SURG committee members related to the October, December, or January meetings, with an understanding that July is pretty well slated at this time. And so if there were any additions for July, that would be challenging. We would need to move them likely to October unless somebody had a suggestion about swapping a presentation out for July.
Thank you, Kelly. I see Debbie Nadler with her hand raised. Debbie? Debbie, did you have a question? Okay, does anyone else have any questions for Kelly?
I do. I'm
Oh, yes,
sorry it
Debbie,
was
back to you,
muted.
yes.
I am so sorry. Yes, and I think Jessica can probably explain this better than me, but I had made a suggestion, or if when we're doing the updates on the last one there, the opioid settlement updates, is there a way to do it in layman's terms instead of like the chart? I guess what I'm asking for is accountability. Like, how much of the money went where, and where did they use the money? And was it effective? And does that make sense? I mean, can it be broken out further so we can see how they're using their money and how much of the money they received was used and where it was used to, and if there was a difference? Am I making sense?
Good point, Debbie. We're making a note of that. So thank you for bringing that up.
And then one other there, I don't know if anybody's heard, maybe Jessica, you've heard of this. There is a new drug that's circling the country, and it's hit Arizona, Texas, some of the East Coast, and I don't know if anybody's checking on it here, but it's called parafluorofentanyl, PFF. They're calling it China White. I know in the past China White was used for heroin. Now it's a nickname for this new drug, and it is, believe it or not, 25% more potent than fentanyl. So I don't know if anybody's doing a study here. We can add that drug to our list to check out, but it's going across the country now.
Thank you, Debbie, for making us aware of that as well.
And that was it. Thank you.
Okay.
Sorry.
No, you're fine. Thank you, Debbie. Do we have any other questions for Kelly regarding the proposed presentations? Do any of our members have any other topics to bring up today for consideration for future meetings? Okay, hearing none, that will conclude item number 13 on the agenda. We will now move back to item number 4. I'm very excited to have Dr. Carla Wagner with us today. She is with the University of Nevada, Reno School of Public Health, and she is going to give a presentation on compassionate overdose response. So before we move on to Dr. Wagner, I see Assemblyman Gray had his hand raised. I wanted to give him an opportunity.
I do. Thank you, Chair. I couldn't figure out how to raise my hand. The stupid taskbar at the bottom was covering it. So I would like to see a presentation. I don't know if anybody else would either, but the medication assisted, it's called MAPT. I can get you more information on it, but the medication assisted treatment to get people off of certain drugs. I guess it blocks some of the receptor cells or something, but would love to see some of that. And it's been brought up here at the legislature, and I think there's a lot of maybe what's the word I'm looking for? Some potential there.
I think that's an excellent point, Assemblyman Gray. We will definitely take note of that and make sure that's considered for a future meeting. So thank you for bringing that up.
Thank you.
Okay, on that, Debbie Nadler, I see your hand raised as well.
I'm sorry, I'm looking at my list and you said new stuff. Do you remember when we had talked about the Good Samaritan law, doing billboards, focusing on that? Is that on the list? Is I don't know if Dr. Kearns is working on that, or I don't know where we are with that, but I remember last year, even Attorney General Ford wanted to get started on that right away. Is that part of what we're going to be discussing, or new on the board?
Dr. Kearns, can I defer that to you?
Certainly, Terry Kearns for the record. One of the recommendations from the response subcommittee was to look at the Good Samaritan law versus the drug-induced homicide. And we did get presentations that the University of Reno, Nevada, CASAT has done numerous educational components to law enforcement and to other members. And then also there has been education campaigns, I think both out of the Fund for Resilient Nevada and also through CASAT. I can get you, Debbie, the information from those presentations if you'd like to see it.
Yeah, that'd be great. Thank you.
Okay, great. Thank you. So now back to Dr. Carla Wagner. She's going to present on compassionate overdose response. So welcome, Dr. Wagner. We're so honored to have you here with us today.
Hi, thank you, Steve, and thanks to all the members of the committee. Thank you for the invitation. It's been a while since I've been in one of these meetings, but I'm happy to see you all. Let me make sure I know what I'm doing here. Share this. And then share this. What do you see? Do you see the right one?
Yes.
Yes.
Great. Okay. My name is Carla Wagner. I am a professor at the University of Nevada, Reno in the School of Public Health. I have several disclosures to make related to this presentation and this group. I think, as many of you know, I have been doing research in Nevada around opioid overdose prevention for many years. I'm funded by the National Institutes of Health and the Centers for Disease Control and Prevention, among others. The information that I'm sharing today comes largely from a 2-day working group that was held in March 2024, where about 40 of us came together to talk about and build consensus around opioid overdose response. So much of what I'm talking about today came out of the consensus building from that meeting. I also gave an extended version of this presentation with Brandon DeLisi from Southern Nevada through CASAT's Opioid Center of Excellence, and the link to that full recording is here if you want more information about that. What I'm going to talk about today very briefly, because I know I don't need to be exhaustive about this in this group, just very briefly, the evolution of opioid overdose death in the United States, and specifically the role of fentanyl. Remind everybody what we already know about what works, and then talk about emerging issues related to synthetic opioids, opioid withdrawal, and the emergence of new opioid antagonist products on the market. And then I'll conclude with the recommendations that came from that 2-day working group about how the community and the scientific community and the harm reduction community thinks we should be moving forward. So just for your reference, this is the paper that resulted from that 2-day summit, and I've included an open access link to the document, so you should be able to access it without having a subscription. And I'm just gonna head off all of the rest of the talk in my presentation by giving you the highlights from this article, which is what I'll talk about in more detail. Essentially, the conversation amongst these 40 experts from across the country, the consensus was that best practice is to consider the standard dose of naloxone as 1 injection of intramuscular or 1 spray of a 4 milligram intranasal spray, and to be cautious about the introduction of newer, higher dose and longer acting products because they have the potential to exacerbate withdrawal symptoms and create barriers to people accessing emergency care. So if you'd like to read the full report, it's available there. I know I don't need to show you this slide, but the point here is we were already experiencing unacceptable levels of opioid overdose related deaths and drug overdose deaths. And then with the emergence of fentanyl around 2015, 2016, 2020, things just got worse. And that's true across the US, and it's also true in Nevada. So the Nevada data here, you can see the brown line is synthetic opioids, which is mostly fentanyl. And what I also want you to be mindful of, and that we should remember to talk about, this gray line that is even higher is psychostimulants with abuse potential. And in Nevada, that means mostly methamphetamine. Fentanyl, as you know, is a synthetic opioid. Synthetic opioids cause respiratory depression, and that is the mechanism of opioid overdose death. Fentanyl is partly responsible for the current opioid overdose crisis in the United States. And as you know, fentanyl and all of its analogs are more potent than morphine or heroin. And so what that means when we talk about potency, what we mean is you need less of the drug to have the same effect. It's used routinely in clinical practice to treat pain, and that happens in settings where respiration can be monitored and supported. So it is not uncommon for anesthesiologists, for example, to use fentanyl in a clinical setting because they are monitoring the patient's respiration and can support breathing in the event that it's compromised. And what we know to be true is that fentanyl-induced respiratory depression can be reversed with opioid antagonists like naloxone. Part of what's happened over the past several years is there's been a lot of circulation in the media and the popular press about myths or mistruths that are compromising our ability to respond to the crisis. So it is a common myth that touching, handling, or even being in the same room as fentanyl can cause an overdose. And I think everybody at this point has seen news responses of somebody brushing off their clothes of a white powder and then suffering from what is perceived to be a fentanyl overdose. The reality is that the rate of absorption for fentanyl powder through the skin is so minuscule that it is not a risk for an overdose. Touching a surface that has been contaminated with fentanyl or touching fentanyl powder is not a meaningful risk factor for overdose. There's also been a sense in the media that all of the drugs that people are getting from the unregulated marketplace have fentanyl in them. That's also not true. Fentanyl is found in many drugs, but we did a study where we looked at methamphetamine and cocaine samples and looked at the prevalence of fentanyl adulteration in those samples from across the country. And we found fentanyl in less than 20% of the stimulant samples that we tested. So while it's true that there is fentanyl in many things, it is not universal. There's also a sense in some narratives around people being tricked into using fentanyl, that people aren't using this on purpose, and that's not true either. In our research with people who use drugs, some people are deliberately using fentanyl, and they're using it quite often and quite safely. Other people are being accidentally exposed. But in my research in Nevada, what we found is that most people are very aware of the potential and do a lot of things to mitigate their own risk for overdose. And finally, there is this myth that has been propagated around fentanyl overdoses being naloxone resistant, meaning that you can't use naloxone to reverse the respiratory depression. And that is simply not true. Opioid antagonists like naloxone can reverse fentanyl overdoses. What we know is working is the thing that we've been doing for decades: overdose response training and naloxone distribution. So as you all know, the first opioid overdose prevention and response program that trained people who use drugs to respond to overdose and administer naloxone was started in Chicago by the Chicago Recovery Alliance by Dan Bigg in 1996. And ever since then, we have been doing this kind of training this way. We teach people to prevent opioid overdoses by avoiding mixing drugs, using less after periods of abstinence, such as incarceration. We teach people to recognize the symptoms of an opioid overdose. Because the mechanism of death is an interruption of spontaneous drive to breathe or respiration, You recognize an opioid overdose by looking for slow or stopped breathing. You look for unresponsiveness, and you look for symptoms of depressed respiration like blue lips or nails. And then we teach people how to respond. And that response is call 911, support respiration through rescue breathing, administer naloxone, and continue to support breathing until help arrives. These are pictures from the very first training that I did in 2006 in Los Angeles, and we've been doing it the same way ever since. Rescue breathing is a critical step in the response. And over time, what we've noticed is that training around rescue breathing has diminished. We've distributed a lot of naloxone in very low threshold settings. And we've noticed that the emphasis on rescue breathing is less than it was in the early years. So since the mechanism of opioid overdose death is respiratory depression, and opioids, no matter what kind, including fentanyl, suppress the spontaneous drive to breathe, an appropriate opioid overdose response must support respiration. Administering an opioid antagonist like naloxone is one way to restore breathing. That's what naloxone does. But rescue breathing or supportive oxygen with or without naloxone is another way. The goal of an opioid overdose response is to restore breathing, and that might happen before the person wakes up. And this is a message that's been lost. So I'm spending some time on it here and emphasizing it because it's really important to reincorporate this back into how we talk about overdose response, especially given newer synthetic drugs like fentanyl, synthetic drugs like xylazine that might complicate the presentation and might make it less likely that somebody wakes up and starts talking before they start breathing. What we need to be paying attention to is if the person is breathing. They might wake up and start talking later. Because historically, when we first started doing this work, the only formulation of naloxone that was available was these 1 cc vials of intramuscular naloxone. So we would give people two 1 cc vials and an intramuscular syringe and teach them how to inject the medicine into a muscle. So the standard dose of naloxone that has been evaluated in community-based programs with people who use drugs is that 1 ml injectable vial. A handful of years later, we had access to the 4 milligram intranasal dose. That's the standard Narcan nasal dose that is now available over the counter as well. So a standard intranasal dose is that 4 milligram formulation. We know that the standard dose of naloxone, whether it's the 1 ml injectable or the 4 meg per ml intranasal, we know that that standard dose is effective in reversing opioid overdoses, including fentanyl. This table shows you how some of the newer formulations of opioid antagonists measure up in terms of their equivalence with that standard dose. So the Narcan branded nasal spray and generic nasal sprays are the 4 milligram nasal spray. That's roughly equivalent to 1 intramuscular dose. There are newer formulations on the market, including an 8 milligram nasal spray that's twice the standard dose, and a 5 milligram injectable, which is equivalent to about 12 and a half vials of the standard 1 milligram injectable dose. In the past several years, there's been a proliferation in the number of opioid antagonist products on the market. All but one of them in this table are naloxone. And as you can see, the formulations range from injectable formulations on the left to intranasal spray forms on the right. There are different concentrations of naloxone in each of these formulations, and they come with a different price point. The only one on this table that is not naloxone is on the far right. It's nalmefene. Nalmefene is a different kind of opioid antagonist that is used clinically. We have no data right now on how nalmefene will work in community-based settings. But what we do know is that nalmefene is significantly longer acting than naloxone. So the effects of nalmefene, the opioid antagonist effect of nalmefene can last 6 to 10 hours, compared to about an hour and a half for naloxone. With the proliferation of new naloxone formulations, researchers have been looking into the effectiveness of those medicines in the field. It's important to note that there have not been any community-based research trials to examine effectiveness. And as far as we know, the newer formulations that have come on the market have only undergone the safety testing required to market them, to bring them to market. And they haven't undergone testing in community-based studies with people who use drugs. So the best data we have about the effectiveness of these newer and higher dose products comes from observational studies. This is a study that was done in New York, where law enforcement officers were carrying 4 milligram intranasal sprays and 8 milligram intranasal sprays in different jurisdictions. So the researchers were able to compare the outcomes among people who got the lower 4 milligram and the higher 8 milligram products. In terms of survival, number of doses received, combativeness upon waking up, and refusal of transport to the hospital. They found no differences between the people who got 4 milligram and the people who got 8 milligram in terms of survival, how many doses they got, combativeness when they woke up, or refusal to transport to the hospital. The only difference that they saw was withdrawal symptoms. Recipients of the higher dose product had 2.5 times higher risk of experiencing withdrawal symptoms, including vomiting, compared to the people who got the lower dose product. So the implication from this study was that using the higher dose product did not provide any additional benefit. In another study done in Pittsburgh, Prevention Point Pittsburgh is a harm reduction organization that has been distributing naloxone since 2005. They mostly distribute kits containing 2 single doses of the injectable or 2 single doses of the 4 milligram nasal spray. And they were curious to know whether their participants, who are people who use drugs, were administering more naloxone as more and more of the overdoses that they were seeing involved fentanyl. So they compared the number of doses received in 2013, when 3% of the deaths in the county involved fentanyl, to 2016. So in 2013, when 3% of the deaths in the county involved fentanyl, 89% of the overdose reversal reports that they got from their participants said they used 1 to 2 doses. And the average number of doses that were administered to reverse an overdose was 1.62. Compare that to 2016, when 68% of deaths in the county involved fentanyl. So the prevalence of fentanyl has gone up substantially. 92% of the overdoses that were reversed in 2016 used 1 to 2 doses, and the average number of doses was 1.5. So what we see here is that even as fentanyl started coming on the market and became more and more prevalent in a place like Pennsylvania, the number of doses of naloxone that it takes to reverse an overdose among people who use drugs did not change. I also have data courtesy of Jess Johnson's team and Brandon DeLisi from Southern Nevada Health District. And this was part of the webinar that Brandon and I did for CASAT. Southern Nevada Health District has data from surveys about naloxone administration by uniformed first responders and lay people, surveys about naloxone administration by people who use drugs, and data from their local EMS. This is a little bit more complicated than the data I showed you before, but here's what we're looking at. If you look at the rows, it's by year. And if you look at the columns, it's the number of doses of naloxone administered. And these are data from reports from first responders and lay people. So what you can see is in 2021, 15 out of, and then what we're looking at in the squares is survival rate. So 15 out of 15 people who received 1 dose of naloxone in 2021 survived. There was a 100% survival rate among overdose victims who received 1 dose. If you follow that column down, you're looking over time, and what you can see is that the survival rate remains fairly consistent. In 2024, 29 out of 29, or 100% of people who received 1 dose of naloxone survived. If you read across the table to the right, you see the survival rate as people received more doses of naloxone. And so what we need to take away from this table is that the survival rates across the board are quite high, and that more doses of naloxone administered does not necessarily mean a higher survival rate. You can see here that there were some cases where people got 3 or 4 or 5 doses of naloxone. Brandon looked at those reports in more detail, and in about 75% of those cases, responders indicated that they didn't wait the minimum amount of time between doses. So they were rapidly administering multiple doses and not giving naloxone time enough to work. A similar story here. These are data from Southern Nevada Health District again, reports from people who use drugs, and you can see a similar story. Survival rates in these low dose, this left-hand side of the table where people are getting 1 or 2 doses, survival rates are quite high. And giving multiple doses doesn't necessarily mean higher survival rates. Oops. And this table shows quantity of naloxone administered by year by EMS. And the yellow highlighted bars show you that the majority of cases received 0.5, 1, 2, or 4 milligrams of naloxone. So 0.5 would be half of an intramuscular injection. 1 would be 1 intramuscular injection. 2 milligrams would be 2 intramuscular injections. And 4 milligrams would be 1 intranasal spray. And you can see that 55% of the cases received 2 milligrams, 23% of the cases received 1 milligram. So what these data are showing you is that EMS over time are also not administering massive doses of naloxone. Most overdoses are reversed with standard doses, 1 or 2 administrations. But we know that people are talking about needing more naloxone and needing stronger naloxone, and we need more because the drugs are more potent, and so we need a bigger and better and stronger antidote. One of the things that's going on is people aren't waiting long enough between doses. There was a study done where they looked at body camera footage among law enforcement officers, and on average, the officers only waited 53 seconds between doses, which means they were rapidly administering multiple doses, which is a really common response when you're in a scary situation and a life-threatening situation. But the recommendation is wait 2 to 5 minutes between doses and support respiration. We have to give the medicine time enough to work. If you took a handful of Advil for your headache and it didn't work immediately, you wouldn't take another handful of Advil and another handful of Advil and another handful of Advil. You have to give the medicine time to work. We also know that in parts of the country that are seeing increased prevalence of xylazine in the overdose complicates overdose response. Xylazine is a sedative. So if somebody has taken xylazine with fentanyl, they might not wake up and start talking even after their breathing is restored. So the naloxone is treating the opioid part of the overdose, but it's not treating the xylazine. So this leads sometimes to a situation where breathing is restored by getting the naloxone, but the person isn't responsive. So people don't think the overdose is resolved and they keep giving more naloxone and keep giving more naloxone. Again, the recommendation here is focus on the breathing. Ensure restored breathing, even if they don't wake up, and continue to support respiration. And then finally, people think, and this is kind of a natural human tendency, people think that giving more or higher doses will speed up the reversal process. And this is a really common line of thinking, especially because we're talking about stronger and more potent drugs. But what we know is that over-medication with naloxone might cause more serious and painful withdrawal symptoms, and that causes problems. So the recommendation is give the lowest dose of naloxone needed to restore breathing. In this case, more is not necessarily better. And the reason is because opioid withdrawal symptoms induced by naloxone can be painful and cause harm. Historically, and especially in the early years, the risk was somewhat minimized. We kind of talked about you can't give someone too much naloxone. But what we know now from experience is that inducing severe and painful withdrawal symptoms by giving too much naloxone can hurt people. It might cause people to use alone to avoid being over-medicated next time. And that using alone is a primary risk factor for death. It might cause people to avoid calling 911 to get help because they want to avoid those painful withdrawal symptoms. It can cause people to use more opioids to try to alleviate those withdrawal symptoms, which can put them at risk of having another overdose. And getting too much naloxone and experiencing that withdrawal is painful and it hurts. And it makes people feel punished and stigmatized. And it can cause agitation, especially if somebody is disoriented and feeling sick. One of the participants at the meeting talked about his own experience of being over-medicated with naloxone, and this is what he said. He said when he woke up, he began vomiting so much that he couldn't breathe, and he was extremely anxious, and that he tried to redose with heroin every 15 minutes to try to feel better from those withdrawal symptoms. But what we all know is that that heroin wasn't reaching his receptors because those receptors were occupied by naloxone. And until the naloxone wore off, none of that extra heroin was going to help. And then when the naloxone does wear off, all of that extra heroin on board puts him at risk of having another overdose. And he said, for months after that, I was hesitant to use around other people. I wanted to use alone to avoid something like that ever happening again. And that put him at a huge risk for dying of a subsequent overdose death. So the community consensus and the scientific consensus at this point is that stronger and longer acting formulations of opioid antagonists might cause more severe withdrawal symptoms that last longer and don't appear to increase survival. So where does that leave us in terms of how to move forward? The basics still apply. Even in a market that is volatile, that is changing, even with the emergence of fentanyl and xylazine, the consensus is support respiration by giving rescue breathing until spontaneous breathing is restored. Give the lowest effective dose of naloxone required to restore breathing, and that means paying attention to over-medication to avoid withdrawal symptoms. Wait and teach people to wait 2 to 5 minutes for the naloxone to work and keep breathing for them and give additional doses as needed. You might need more doses, but if you give multiple doses in the first minute or in the first 2 minutes, that's not going to make that's not going to help. And overdoses might take longer to reverse in the presence of these other synthetic drugs. So again, we have to pay attention to breathing. So in summary, and these are the summary points from the workshop, and you can refer to that paper that I shared earlier for more detail. But the recommendations at this point are effective opioid overdose response must restore breathing, and that has to be a primary focus. And that might mean reconfiguring some of our training and educational materials to really get people to focus on breathing. Precipitated opioid withdrawal from too much opioid antagonists is a serious concern and can cause harms and should be avoided. And the best practice is to administer the lowest effective dose of naloxone, the lowest dose needed to restore respiration while avoiding withdrawal. I think you have a copy of these slides, but also at the end, I have a set of references for you if anybody would like to do more reading. And I am, of course, available to answer any questions that the committee has.
Thank you so much, Dr. Wagner, for that great presentation, as always. I do see Debbie Nadler with her hand raised, so I'll turn it over to Debbie.
Thank you. That was one of the best presentations I've seen in a long time. Thank you so much for breaking it down like that. But I do have a question to ask you, and I keep seeing it. I run a lot of groups across the country with a lot of moms who lost their children to this horrific epidemic. And there seems to be a constant battle of this. People are saying that their children were using marijuana and it was laced with fentanyl, and their children died from the fentanyl, not from the marijuana. I mean, I can't tell you how many people are arguing over this. And then other people are saying if you smoke it with marijuana, you can't overdose. Can you explain anything you've heard about fentanyl and marijuana mixed?
Thank you, Debbie. It's an important question, and I don't have an answer for you. I was on a call yesterday where we were talking about this, and I didn't have a chance to read what they sent us. I guess the one part of that I can address is what we know from people who use drugs, especially people who used to inject heroin, is they have moved towards smoking fentanyl because they can manage it better and it reduces their risk for overdose. So I mean, I don't think there's any credibility to the idea that if you smoke fentanyl with marijuana, you're not going to overdose. I don't have any data to speak to the prevalence of fentanyl in marijuana. The drug checking programs that I work with, people aren't submitting marijuana samples, but I can do a little more research on it.
That would be great. It's just spreading like wildfire across my groups. And I'm like, is it true? Is it not true? But thank you. Thank you.
Do we have any other questions for Dr. Wagner?
Sorry, Jessica Johnson, for the record, I have a quick question, if that's okay.
Yes, Jessica, please.
Well, two, if there's time. Dr. Wagner, appreciate your presentation. Thank you so much for coming today. I had two questions. I'll ask the first one, and then if there's time, I'll ask the second one. I've seen kind of referencing what Debbie was sharing, some articles and heard from some other groups about some of the pharmaceutical companies representing some of the drugs you mentioned, approaching groups like public safety groups or law enforcement, maybe city and county leaders directly, and sharing some of their research. I know you have kind of mentioned the lack of research to date in the community setting, but one of the things that has been brought up in those presentations is around noxious brain injury. I'm probably saying that incorrectly. I don't know if that's something you have heard of related to maybe a reason to administer a higher dose of naloxone. I was just wondering if that came up in the work group at all, as discussed.
Thanks, Jess. Are you talking about hypoxic brain injury? Like,
That's what I'm talking about. Thank you.
the concern that somebody has gone without oxygen for too long and therefore is going to suffer brain injury related to the hypoxia.
Thank you. Yes, that's what I'm talking about.
I am not a physician, but the issue there, and so if there's, I don't know, maybe Terry actually can speak to this better than I can, or any of the physicians in the room, but a higher dose or longer acting product is not necessarily, we don't have any data that a higher dose or longer acting product is going to reverse an overdose or restore breathing faster. And to avoid hypoxic brain injury, you need to get somebody breathing. So based on my understanding of how this works, I'm not convinced that a higher dose product would restore breathing any faster. And the basics still apply. You have to support respiration through rescue breathing.
Jessica Johnson, for the record, thank you for that answer. I see Terry also nodding her head in the room here, so I appreciate that. And thank you. I'm clearly not a physician either, based on my phrasing of that question, so I very much appreciate it. One other question, if appropriate. You had mentioned nalphamine in the original slide and had mentioned that at least the clinical data is sharing that the effects sort of last longer, or perhaps it takes a longer time for the nalphamine to leave the receptors of the brain. And I'm curious if you could share more about kind of why people, like what would be or is there a risk associated with that from your perspective? Like, why wouldn't you want something like nalphamine to last longer in the brain?
That's a good question. Yeah. So nalmefene is an opioid antagonist. It has been used in clinical practice. My physician colleagues in Mexico are quite familiar with it. They use it in emergency medicine in Mexico quite often. I don't think we use it as much in the US. But it's a longer acting opioid antagonist. So it means it's going to sit on the receptors for longer and it's going to block those receptors for longer. The concern is precipitated withdrawal and the duration of experiencing opioid withdrawal symptoms. So naloxone lasts 60 to 90 minutes. If somebody is experiencing withdrawal, you can manage that withdrawal and they will be feeling better within an hour. If somebody has nalmefene on board and they experience precipitated withdrawal symptoms, they might be experiencing those withdrawal symptoms for 6 to 10 hours. So that's a very long time to be experiencing very painful opioid withdrawal symptoms. And it's a huge deterrent. It's going to create a lot of fear, and it's a huge deterrent for people seeking help. We don't know what's going to happen. We haven't seen it used this way. And there is no research on it. So the harm reduction community's fear is we know that there are potential harms here, like big potential harms. We also know that the medicine we already have works. So what is the benefit of introducing this unknown that could potentially cause more harms and serve as a greater deterrent?
Thank you.
Terry Kearns, I have a question, if I may.
Yes, Dr.
Co-chair.
Kurtz.
Dr. Wagner, again, thank you. A really good presentation. I appreciate the information. My question has to do with the general practice for teaching CPR classes now is compressions only and not rescue breathing. But we know that in the training for overdoses, we do teach people about rescue breathing. Is there, and it's generally because that, for heart attacks, those sorts of things, the rescue breathing really wasn't any more effective than just doing compressions. Is there any push to try to get rescue breathing put back into CPR courses?
Thanks, Terry. That it's an important insight, and it's something that we've been talking about for many years, because hands-only CPR to respond to heart attacks was introduced many years ago, and it is in conflict with what we teach for opioid overdose response. There is guidance out there, and there has been some papers written talking about the recommendations for rescue breathing. And I think even the AMA has weighed in on it. So in terms of movement to change how AMA is teaching CPR, I don't know. But it is an issue to contend with. And the other issue to contend with is that people are a little bit squeamish about giving rescue breathing. And so it takes a lot of confidence building and capacity building to convince people to do it. But it really is the most important thing that somebody can do. So that's not an answer. I'm sorry, Terry. Just that you're right.
No, I appreciate that. And I know that some places that do CPR training that include the overdose protocols do touch on rescue breathing. So.
And the other thing, just so people know, the protocol for naloxone administration and rescue breathing is also integrated into the 911 dispatch protocols. So if you call 911 and you tell them that you have naloxone, they will walk you through rescue breathing. The dispatcher will walk you through it. Not everybody feels safe or comfortable calling 911, so that's only going to work for a subset of people who feel like they can make that call. But that is a resource that's also available.
Thank you, Dr.
Kudos,
Kearns.
thank
Dr. Wagner. I see that Assemblyman Gray has his hand raised. I'll turn it over to him.
Thank you, thank you, Chair. Yeah, I'd like to thank you first for covering the agitation that a lot of these folks feel when they come out when they're given too much naloxone. That's something when we first got it in the field many years ago. I think it was 93 or 94. We started getting in the field. I mean, it would always take, the medics, the firemen, and the cops to hold them down, and it was always a problem. So I'm glad to hear that they've actually got the dosing a lot better, because it used to be you just interrupt their high and you're done, and they're coming out and they have no idea what's going on. But the other thing I was going to say, so with the anoxic, it's actually anoxic brain injury. It's ABI. That's the total lack of oxygen within the bloodstream, as opposed to hypoxia, which is a slow reduction in oxygen. And that's when the damage actually occurs, is when there's no oxygen. Not that it's a big deal. I mean, they're both going to lead to the same end, but it's I'm concerned also that they're not recommending the the mouth to mouth anymore. I mean, the barrier's there, but no, I think you hit it on the head. People are just not there anymore, wanting to do the rescue breathing. So it's still something really critical. I mean, you've got two different mechanisms of injury. I'll say, a lot of them, with the rescue breathing, with cardiac arrest, you're dealing with a different problem. The heart is, one of the coronary arteries is blocked or something like that. So it's not, you still have blood in the bloodstream. The heart's not pumping it. But with the with the overdose, if you can initiate that rescue breathing, and you can get that heart going again, and you're going to avoid a lot of injury. So it's just two totally different mechanisms, and I don't know why they don't come out with two different protocols. They really should. I mean, if it's an overdose, then you really should.
Yeah, thank you. There are two separate protocols. So AMA is teaching CPR for heart attack, but the protocol for overdose response is different for exactly the reasons you're saying.
They're
Yes.
teaching the protocol for overdose with rescue breathing now.
Well, that's what it's always been.
Okay, well, no, I don't know. It was
Yeah.
never. I've been out of the field for a little while now. I haven't been in an ER for quite a while, so I'm not up to speed on what they're actually teaching with first responders any longer,
Yeah.
or ER staff.
It's always been. And if you talk to paramedics who are in the field now, a lot of times people, they will support respiration and ventilate and not even administer naloxone. If they know that they can keep somebody breathing and transport them, they'll do it without naloxone.
Yep, that's a good way to do it as well. It's especially if they've got the positive pressure, which when I first started we didn't have. So we had the bags. So alrighty, thank you.
Thank you, Assemblyman. Do we have any other questions for Dr. Wagner? Dr. Wagner, thank you again. This was such an important presentation. This was requested by our members at our December SURG meeting. So we're so grateful you could be here today and share all of this wonderful information. So thank you again for being here. We look forward to seeing you again soon. Thank you. Okay, moving on in our agenda, I will now move on to item number 5. This will be an update on the opioid litigation, settlement funds, and distribution. So I will turn it over to Chief Deputy Attorney General Mark Kruger. Hello, Mark.
Hi, everyone. I don't have a ton for you all today. Oh, sorry, Mark Kruger, Chief Deputy Attorney General, Bureau of Consumer Protection, for the record. I don't have a lot of new updates. The Purdue bankruptcy is getting nearer to potentially settling with both a new plan confirmation for Purdue and potentially another settlement with the Sacklers. We just have to continue to wait probably another month or so before we should see the final documents come through. Good news is that the Kroger settlement was finalized. Payments were made by Kroger to the administration settlement trust, and those will be distributed in April, about April 15th or so. So we'll be seeing another bunch of money coming through the One Nevada agreement shortly. The only other thing I wanted to highlight was, remember that we do have the online dashboard where you can see where the funds have come in. And in addition to that, you can see where the state's expenditures are. We're also in the process of creating a reporting mechanism, an online reporting mechanism for the counties and local governments to report in the use of funds. And with them reporting in the use of funds, we'll be able to see a little bit more of how those funds are actually being used. That's it for my update.
Thank you, Mark. Do we have any questions for Mark?
Oh, wait, one more thing.
Yes.
We had the PBM litigation was removed to federal court. It was since remanded this last week back to a state court. So we should be starting discovery in that matter, although the defendants in that case have appealed to the Ninth Circuit, but have not yet gotten a stay, although they're seeking one. That's
Right.
it for now.
Thank you, Mark. I see Debbie Nadler with her hand raised. I'll turn it over to Debbie.
Thank you. I have a question for you. So our money is kind of divided in a pie, correct? I'm just trying to remember certain things. I know part of it's going to Medicaid, part of it's going to the government, and part of it's going to the state of Nevada. When you're showing the charts on where the money's going to, is it, I guess, and forgive me if I'm misunderstanding this, but where's all the money coming from? The state of Nevada, the 43%? Is that what we're allocating? Or the local government's 38%, or the Medicaid match 17%? I think that's around the figures I remember.
Sure, I can provide an overview of that again. So remember, the Medicaid match is a little bit of a misnomer. It was a way of determining certain funds. There's a whole story about why it was named Medicaid match, but it has nothing to do with going to Medicaid. None of that money goes to Medicaid. So the money itself comes in from various settlements or bankruptcies. The settlements are usually signed on to by the state of Nevada and all of the signatories to the One Nevada agreement. So when everyone signs on, you maximize the dollar amounts that you get as a recovery under the settlement. If the local governments didn't sign on, the amount of money to the state of Nevada itself would be reduced. So that's how we've maximized the amount of money that comes in. When it comes in, it gets divided to roughly those figures. The percentage that's allocated in that pie chart that's in the One Nevada agreement goes to the state, which goes to the Fund for Resilient Nevada. All of the rest gets allocated in two different mechanisms to local governments. The Medicaid match portion that's there gets allocated only to the counties. All the rest goes to the counties and other signatories to the One Nevada agreement that are local governments. Does that make sense?
A little bit more. I guess my question is any of the money where it says the local governments? I've seen in other states that 8% of the lawsuit money has gone to other sources other than the opioid epidemic. Is there any allocations for anything other than strictly the opioid epidemic? And I'm not questioning y'all's integrity or anything. I'm just reading other states and seeing, and I guess that pie chart had me confused.
Yeah, no problem. The money is allocated only for opioid abatement. Now, some like I think there might be some other settlements, but the majority of settlements have a cap, and especially the bankruptcies have a cap on what can be used for administrative expenses related to that use of opioid for abatement. And there's all kinds of different list of approved uses that are in the settlements. And we have put all of those on the Fund for Resilient Nevada's website. So you can actually go there and look at each settlement and see what the uses are. Some of them are overlapping uses and others are unique to those settlements. So the local governments are also restricted to use that money for abatement only. They're not allowed to use it for anything else. Other states would be in violation of those agreements that are national agreements,
Oh, no.
but potentially could have had their own individual agreement where they were allowed to use the money for another purpose. But I'm not aware of any of those.
Okay, and then the local government, when you're putting up that list, because I do watch it, and thank you for doing that. When you're putting up that list, it includes all three pieces of the pie? The money from all three pieces of the pie? Does that make sense? Can you hear me?
Yeah.
Maybe he can't hear. Whatever.
Debbie, I wanted to say that I think what you may be referring to is the Foundation for a Resilient Nevada report, and that's going to be in our next presentation in a moment. So you
Okay.
might get the information you're looking from in that presentation.
Okay. It's that pie chart that always has me confused because I don't know what goes to what.
I think we may have,
Sorry
oh, there's
about
Mark.
that.
I thought-
I got disconnected. I apologize, but I'm back now. I hope that answered the question. I think I was done before I got disconnected.
Well, it made more sense and I appreciate it.
And Mark, just so you know, we have Don Yohe presenting next. So I
Okay,
just shared
perfect.
with Ms. Nadler that Don may certainly answer more of Debbie's questions.
Yes,
Thank
Yes.
you so much. Thank you.
that's great. Thanks, everyone.
Thank you again, Mark. Okay, that will conclude item number 5 on our agenda. Before I introduce our next speaker, I wanted to share that I'm going to sign off in a moment, and the remainder of the meeting will be chaired by Jessica Johnson. So item number 6 on our agenda is a presentation of the Fund for a Resilient Nevada. All of our members recently received the 2024 report. Here today with us is Dawn Yohe. She is with the Nevada Department of Health and Human Services in the Director's Office and oversees the Fund for a Resilient Nevada. So on that note, I will turn it over to Dawn. Thank you so much for being here, Dawn.
Hi, thanks, Chair and members of the committee. Dawn Yohe. I am a clinical program planner with the Department of Health and Human Services Director's Office, and I assist with the oversight of the Fund for Resilient Nevada, the state's portion. So this was a nice little segue. I'm actually going to be sharing our dashboard. Let me find it. All right, can everybody see the dashboard?
Yes.
Yes.
Perfect. So what Mark was talking about a little bit, so what I'm going to be going over today is the dashboard. I heard you guys kind of wanted to go through this and walk through it a little bit. I am going to be talking a little bit about our annual report that was delivered at the end of January, as well as some of the One Nevada signatories and their report to the department. So this is the dashboard. The goal of the department is really to make this very transparent. On this first page, you'll see we have the Fund for Resilient Nevada website. We also have the One Nevada agreement on here. Everything that we fund is linked back to the Nevada Opioid Needs Assessment as well as statewide plan. We do have to update this little portion, this FRN annual report here to be more current, but you would be able to find our annual report here on this dashboard, as well as the allowable uses of the fund. On this site, on this tab, you will have the financial overview. So this is the Nevada total opioid recoveries. If you just left everything open, you would see that we would have about 1.1 billion in actual and estimated costs. If you wanted to see how much estimated dollars are going to be coming into Nevada in 2025, here's your total recoveries or your estimated recoveries for the total calendar year 2028. You can even go down here and be like, how much is Allergan going to be giving the entire recovery in 2028? We say actuals and estimates because as they come in, we make them actuals. So in 2022, this is actually what we got, and in 2023, these are the actual dollars that were brought in. We have broken this down even more. So this is the FRN, the Fund for Resilient Nevada recoveries. So these are specific to the 43% that comes into the state's portion. Again, if you hold the control button and you want to see, okay, in 2021, 22, and 23, how much the total was, you can do that. Easy to kind of play around with the estimates as well as the actuals. And then broken down again into the One Nevada signatories for the counties as well as the cities. I'm going to stop here for a second. Does anybody have any questions? Okay. So moving on into this dashboard, the goals you will see here are our funded providers from our category 10 as the state. And so these are in line with our statewide plan. So same concept, we have the overarching goal, goal number 1 is ensure local programs have the capacity to implement recommendations effectively and sustainably. We're going to go down here to a vendor, for example, our vendor CASAT. You'll see here's the overall financials. So in this first box up here, I don't know if you can see my little cursor, but it has the $5.6 million in our authority budget, how much we have allocated, and then the dollars spent. And then we have vendor specific financials. So you can go down here and you can look at, Carson Tahoe is an awarded provider with us. CASAT, Changing Smiles Pediatric Dentistry. You can look here to see what vendor you want to see, the vendor description, how much was awarded to them, how much they have spent, and what their balance is. And then if you want it broken down a little bit more, we do have the sub-grant information in here of how many dollars are specific to their administrative costs, their equipment, their operating, and personnel, etc. We do that for every goal. So goal 2, 3, 4. And then as we're moving along, this one is blank, but we're currently updating it. So feel free to go in here. I know we don't have a ton of time, so I won't go through every single one. Any questions on this dashboard?
Thank you for Jessica Johnson for the record. Thank you for your presentation, Dawn. Does the committee have any questions for Dawn about the dashboard? Okay, great. Dawn, you have a next component to your presentation. Thanks for the walkthrough on that.
The next part is the annual report, and then we're going to be getting into the One Nevada agreement as well as the signatory projects and spending. Debbie, I think this is the chart that might wrap your head around a little bit more of how the dollars are allocated through the One Nevada agreement. So you have the One Nevada agreement and then the opioid settlement funds. This 43.86% is specific to the Fund for Resilient Nevada, which is the state's portion of the fund. All the money goes into the Attorney General's office and then it's allocated directly from there. The local governments received the 38.77%, and then the Medicaid match allocation was also allocated to the counties by population. So that 17.37 also goes to the counties by population. So by population, of course, it goes to Clark and Washoe with the remaining counties by population.
Perfect. Thank you.
You're welcome. Some of the goals that we talked about that you'll see in the annual report, this is just a very high level. Goal 1, to ensure local programs have the capacity to implement recommendations effectively and sustainably. Goal 2, prevent the misuse of opioids. Goal 3 is to reduce harm related to opioid use. Goal 4 is to provide behavioral health treatment. Goal 5, implement recovery communities across Nevada. Goal 6, provide opioid prevention and treatment consistently across Nevada in the criminal justice and public safety systems. And then goal 7 is to provide high quality and robust data accessible timely reporting. We were able to complete a couple of studies last year as well. We did a health outcomes of infants with gestational exposure to substances in Nevada. And this study looked at outcomes in 6-month intervals from birth to age 2. And it compares the substance exposed infants with non-exposed counterparts in terms of hospital admissions and emergency room diagnosis, subsequent CPS involvement and mortality, and looks at different areas that we might be able to make impact. And then another study that you will find is the substance use and criminality in Nevada. This analysis showed a very significant link between substance use and criminal activities. More than 45% of Nevada's forensic patients self-reported drug use, but this study was constrained by limitations of available data. We went ahead and linked that here for you guys. Also in the report, you will see our funded projects. This is just very high level. However, in the report, you will be able to see what their goals were, what their objectives were, how it relates to opioid abatement, and some of their outcomes. So in goal 1, we have our opioid training and technical assistance center, which is nationally recognized. It's the Nevada Opioid Center for Excellence. The Nevada Indian Commission, we do fund a program position in order to do coordination with tribes here in Nevada. And then we did do a supporting Nevada's children training and coordination with Nevada Public Health Foundation. Goal 2, you will see, and this is just in calendar year 2024, the multi-tiered systems of support. MTSS was funded for prevention, Nye County Communities Coalition, Youth in Transition, as well as the Boys and Girls Club Smart Moves statewide opioid initiative. Harm reduction, we do fund Track B Exchange, also known as Impact Exchange, to access needles, which is sharps and sharps containers and vending machines. We have an allocation for overdose reversal medication and testing strips, as well as Dignity Health chronic pain self-management program. Treatment, mobile recovery units, empowered pregnant and postpartum opioid support, living free health and fitness, transitional living, Carson City Community Counseling Center residential program, alternative sentencing treatment program to support, it's the Support and Treatment Accountability and Recovery STAR program, Northern Nevada Hopes prenatal care program, Quest Counseling, youth and transitional aged youth project, and then Lyon County Resilient Families program. In goal 5 for our social determinants of health, we are funding a Raise the Future foster navigation for older foster youth. Goal 6 is funding the Division of Health Care Financing and Policy, which is DHCFP, their 90-day pre-release waiver for jails and prisons. We do have a Nevada Rural Jail Opioid Disorder Research and Implementation project going on right now, which looks like you guys are going to hear from in July. And then we have our Holistic Defense Resource Center. Goal 7 for data. We have been able to launch a handheld mass spectrometer project. We pay a portion of the all payer claims database, the overdose detection mapping application for ODMAP. We pay the API connection to EMS, as well as a portion of the poison control hotline. All these projects that you're going to be seeing in the report, and it's very lengthy. So I do recommend taking the time to go through all of that and then coming back to us if you have any questions. All those projects were funded in calendar year 2024. You will start seeing more of the FY25 awards in the dashboard. So if you have questions about any of those projects, please feel free to email us or contact us. And then once the biennium budget is approved, or if the projects are approved or not approved, all of those projects will be going into the dashboard as well. So you will start seeing the FY26 and 27 biennium funded projects, if they're approved in the dashboard as well. And then just a nice visual. So this is an allocation for FY 24 and 25 by population served. And so I'll just kind of let you guys look at this for a second. And then do you have any questions on this portion?
Thank you, Dawn. Any questions from the committee on what Dawn has shared so far? Debbie Nadler, go ahead.
Yes, thank you very much. Can I ask you a question about on goal number 4? I just remember in my head the 2 questions. One was under goal 4 and one was under 7. And I think under 4 is something about the mobile units. If I go in there and click on it, will it show where those are? Because are they in Clark County, the mobile units?
The mobile units were purchased through the Fund for a Resilient Nevada, and then there was some question on who was going to be funding the staffing, which our department just took over because we wanted the entire project just to kind of sit under one entity. And so that it'll be 3 different entities are going to be housing a unit. One will be down in the southern region, one is actually up here in Carson, and the other one will be in the rules. So
Perfect. Yeah,
all
I was
over.
glad to see that. And then on number 7, I took a snapshot of it. I had a, I'm sorry. I know everybody wants to get out of here. Let me just find it. Oh, the poison control hotline. So if you funded them already? Because
We fund a
they
portion of it based on a subject matter expert report that was delivered to us when the litigation was still going on. So we fund I can get you that, Debbie, but we just fund a small portion of the poison control hotline based on how many opioid calls were going into there.
Because I had a call a couple months ago and they charged me $75 to call.
Oh my. Okay.
I'm just was wondering about that.
I'll look into it. Yeah.
Okay,
for
thank
letting
you.
me know.
Thank you. That was it. Thank you so much.
Thank you, Debbie. Any questions from other committee members? I had a quick question, Dawn. This is Jessica Johnson for the record. Under goal 7, the high quality data with the handheld mass spectrometers, will your team be receiving data on the outcomes from the items that are scanned with those?
That is the goal. We ended up, so our partners over at the Division of Emergency Management were so helpful in being able to help us purchase them as well as get them out to some of our communities. We realized that it was a little bit better of a fit with our partners at the Department of Public Safety, since they do have their internal investigations unit over there for narcotics. And so we just had to switch vendors, but that is the goal. Yes, we're going to be collecting that.
Okay, thank you. Do you have additional components to your presentation, Dawn?
Yeah.
All right.
So here we go.
Seeing no additional questions, take it away.
Okay, so I think this is the part where a lot of the questions were like, hey, how are the counties spending their dollars? This is how the counties are spending their dollars. So through the One Nevada agreement, there is that other portion of how counties spend their dollars. The department has no, like, we do not oversee the counties and how they spend their dollars. However, we are coordinating with them to make sure everybody's, spending their dollars appropriately. I went ahead and I broke these down into regions. And I will get this to you because some of these are just very long. So, for example, Carson City, what you're going to be seeing on most of these slides is a project name, a category, a target population, and total expenditures of what they spent on that project. I don't know if you want me to go through all of this stuff, but I think because we have around 29 or 30 signatories, that will take a little bit too much time. So I'll just kind of run through the slides. Tell me if to stop if you would like me to.
Okay, thank you, Dawn.
So again, in the northern region, we have Carson City. I'll just leave this up here for a second. A lot of their dollars are going towards prevention, treatment, criminal justice, as well as training. Central Lyon County, we do have 2 fire protection districts. Central Lyon County is spending their dollars on purchasing of opioid antagonists. And so they get a very small amount of money, and then here's their expenditures for first responders and harm reduction. Churchill County, spending dollars on research as well as prevention and criminal justice. Douglas County, prevention, treatment for adults, treatment for youth, as well as building capacity. City of Fernley, we have Healthy Communities Coalition for prevention, and youth is your target population. Lyon County, building capacity, data, prevention, secondary and tertiary prevention is identified and highlighted here. Story County, also doing capacity building, case management, wraparound services, identifying some of the rural veterans and at-risk populations. In the rural region, Elko, their project is the Elko County Drug Testing Laboratory. And total expenditures for criminal justice, adult, juvenile, as well as treatment. City of Ely, some expenditures for White Pine Youth Center. Eureka, no reported projects or expenditures in 2024. Humboldt County, the Hope Project for adults and youth and expenditures. Lander is spending some dollars on training and the opioid needs assessment in their county. Lincoln, no expenditures reported. Pershing as well. City of West Wendover, prevention group will be, they haven't spent any dollars yet, but they are expecting to have expenditures in 2025. White Pine County, for furniture and drug court supplies, as well as training and education. Clark Region, Boulder City has a drug court program, training as well as prevention expenditures. Oh, sorry, Christine, do you have a question?
Yeah, one slide back, I think it was for drug court and furniture. How can we get a little more detail on what exactly is that all about?
I can get you a little bit more detail on that.
Thank you.
That's just what they report to me, so I can connect with White Pine to see exactly what that is.
Appreciate it.
Okay, so training, prevention for Boulder City, Clark County. We have criminal justice, medication assisted treatment program, and then the opioid or the community opioid treatment center, Las Vegas Boulevard, as well as community opioid treatment center below. And this would be under capacity building, infrastructure development, as well as treatment. City of Henderson, fentanyl awareness, social media, advertising, and outreach campaign. City of Las Vegas is reporting projects for the City of Las Vegas Municipal Court Specialty Court Program, for harm reduction as well as criminal justice and adults. City of Las Vegas Courtyard Homeless Resource Center, Psychiatric Health and Wellness Clinic, harm reduction and treatment, as well as Catholic Charities of Southern Nevada Renewing Hope Program for harm reduction, treatment, and recovery communities. Looks like some of their expenditures were zero, so it was probably just a project that they're saying they're going to do, and then they'll start billing in 2025. Debbie?
Yeah, unless I missed it, I don't see anything on prevention in Las Vegas, Clark County. I mean, it looks like Henderson's doing fentanyl awareness and everything. Am I missing it? Is there nothing on prevention for our kids or anything in Las Vegas, Clark County?
I mean, this is just what they report to me, Debbie. These are the areas that they are targeting as far as the category. I can go back and check the spreadsheet. However, I mean, I took everything directly off the spreadsheet as far as Clark County is really working on a lot of the capital projects with their opioid dollars in order to build like opioid treatment centers.
So basically nothing with prevention. If you find something on prevention, because I've looked through the website and I didn't see anything. I see that Reno has prevention, not us.
Yeah, I'll take a look, Debbie, and then, you know,
Okay,
this is
that'd
all
be
good
great.
information for us to have as well, so that maybe it's something that we as the state come in and be like, hey, you guys are doing a lot for your capacity building and treatment. We're gonna come in and help with some of the prevention efforts. So
That's great. Thank you.
all
Thank
good
you.
information to still have.
Thank you.
North Las Vegas, no reported projects or expenditures in 2024. And then Mesquite, they have the LEADS program as well as the counseling of drug court families. I mean, this one's prevention as well as treatment.
Not Vegas.
It's around there. So, all right. And then moving into the Washoe region. Washoe's looks a little bit different because they did report on every single opioid dollar that they have as far as like any other grants they have, like SOAR dollars and SEPTRs and whatnot, but I did break it out so that this is specific to the opioid recoveries, their expenditures, and then who they're funding. So they're doing a lot of treatment, harm reduction, medical detox. City of Reno, their project is reducing opioid use disorder. It's a pilot for prevention for individuals who are homeless. City of Sparks, mental health programs for Sparks Police and Fire, harm reduction, and first responders. They did give a little bit of money to the 2024 Northern Nevada Opioid Youth Summit, as well as the Life Changes Center for treatment. Southern region, Mineral County has a Project Magic, which is criminal justice and treatment for youth, as well as harm reduction vending machines. Nye County has a lot of different things going on. High level, they identified their needs, and then, you know, incapacity prevention, identification and referral, as well as treatment, and then some of their expenditures for a grant analyst. Pershing County, no reported projects. I feel like I said that already. I'm sorry if I did. All right, so that is now the end. So are there any questions?
Dawn, thank you so much for your presentation. This is Jessica Johnson for the record. Any additional questions for Dawn? I appreciate you taking the questions throughout as well.
And just something to kind of highlight as well for, this is what Mark was talking about, is like the reporting. We're trying to get this reporting mechanism up on our website so that'll show up on our dashboard as well as we are asking about outcome measures. We do ask about scopes of work as well as outcome measures that aren't shown in this presentation, but I do have some of that information as we start moving these projects along.
This is wonderful. Jessica Johnson, for the record, I just wanted to make a comment. You presented this so eloquently. This is so much work to pull together. I know this has been a ongoing request, and I just really appreciate the time, effort, and energy that your team took to pull these reports together, and inclusive of the 2024 expenditure pieces as well. I found that really valuable, and just thank you for the work that went into that. Any additional questions from the SURG committee? Wonderful. Thank you again, Dawn, for your time and the presentation today. Very thorough. I really appreciate it. I'm going to recommend that we take a brief break as the committee. I'm going to look to my SEI colleagues to see how long that break might be.
9 minutes.
9 minutes. We're going to take a 9-minute break that will put us up right at 4 o'clock to come back for the rest of our meeting today. So see you all back here at 4 o'clock. Thank you. Agenda. Hi, everyone. Welcome back. Jessica Johnson for the record, resuming our SURG meeting today. I am hoping everyone's been able to rejoin us. We're going to move on to agenda item number 7, which is a presentation on legislative bills from the Behavioral Health Policy Boards. Really excited to welcome Dorothy Edwards, Valerie Haskin, Mark Funkhauser, and Sherilyn Rahr-Wood. I just reminding the presenters, each folks have 5 minutes, and I'm asking if we can hold to the SURG group, if we can hold questions to the end of the presentation. Over to you all.
So, hello, Kim, were you? Hi there. All right, don't start my 5 minutes yet. I'm going to talk super fast. Good afternoon, everyone. My name is Dorothy Edwards, and I have the pleasure of serving as Washoe Regional Behavioral Health Coordinator. I'm going to briefly go over Senate Bill 47, the Washoe Region's Behavioral Health Policy Board, and I'm going to read to stay on time. You see the title, Behavioral Health Insurance Parity in Nevada, a study. And before you roll your eyes when you see the word study, I want to share just quickly what we're trying to do and why. Next slide. One of the more important slides here is what is parity. So parity in healthcare refers to the principle that mental health and substance use disorder treatment should be covered by insurance on equal terms as physical healthcare. There's federal laws that deal with parity, and in our 2021 session, you might remember Assemblywoman Peters presented AB 181. That bill required parity data to be shared with the state and reviewed proactively by the Division of Insurance, building on federal law. SB 47 seeks to expand on our work and initiate a comprehensive study of insurance parity for behavioral health care and other medical care. The study aims to develop policy recommendations that address the unique behavioral health needs of Nevada residents and ensure equitable access to care across the state. SB 47 is a critical step towards addressing gaps in behavioral health coverage that leaves many Nevadans without the care they need. We want to analyze metrics such as network adequacy, reimbursement rates, denial of coverage, emergency care utilization. The study will provide essential insights into how current insurance policies impact access to behavioral health care. The findings will guide the development of tailored solutions that consider Nevada's unique challenges, including its rural and urban disparities, workforce shortages, and limited insurer pool. The study will also evaluate compliance with the Federal Act, identifying opportunities for Nevada to implement innovative policies that improve care quality, reduce costs, and enhance outcomes for individuals and families across the state. We've not looked at parity as a holistic review of the effects or the lack thereof. So before creating another piece of legislation that felt punitive or wasn't able to be followed or not followed at all, our goal is really to assess compliance with federal laws and identify the gaps in coverage. Where do we lack? Where do we need to improve? Workforce issues, there is a direct nexus between the two, and economic impacts of inadequate behavioral health care. Next slide. The federal law is the Mental Health Parity and Addiction Equity Act that addresses parity and equity between mental health and physical health services. There have been revisions, but there continues to be gaps, which I've addressed a little bit. There exist disparities in reimbursement denial rates, authorization requirements, and provider networks, and ultimately an economic burden carried by the state, the community, untreated behavioral health conditions. Next slide. The study will be designed to be conducted in several phases. There is data collection being done now by different entities, and I don't want to imply there hasn't been. DOI, PEP, DHHS, and Medicaid, to name a few. The bill provides, this bill, that DOI, Division of Insurance, gives them the ability to require additional data that may fill gaps with the help of an outside provider, such as the Gwynn Center, who we have chatted with. Provide comprehensive analysis, not only to measure how we're doing internally, but also for comparison to other states. The goal is to have a level playing field and to be representative of Nevada as a whole. So next slide. So how are we going to accomplish that? The goal is to secure funding with a partner and contract with expert researchers, which I know sounds really easy and not necessarily will be. We have met with the Division of Insurance several times to discuss the elements and have had great discussions. You may have seen a fiscal note if you've looked at the legislative website, and we've had good discussions, and Phil will be able to address that once the bill moves to finance. Understanding their limitation on resources such as staffing, we're working on some good proposals. So I would invite you to stay tuned. I wasn't prepared to go into the details of that. And as I am speaking, actually, our team is working on some friendly amendments. So that's exciting to hear. The reason to require the annual report is to ensure data is analyzed regularly and received, which will allow legislators and policymakers to be informed along the way. We do that to help them out of respect rather than just throw everything at the end and then hope we get it fixed. So that's the reason for an annual report. The next slide. So I took about 10 slides and narrowed it down to this one. The expected outcomes, they're ambitious, but we went big. We want to identify workforce and economic impacts for which we know, as I said, there's a direct nexus. We want to identify insurance gaps and enforcement challenges, recommendations for legislative and regulatory improvements. So this is, in my mind, really one of the biggies. And then strategies to enhance access and affordability for behavioral health services and care. Next slide. So look at how good I'm doing. So by requiring a comprehensive study, SB 47 will provide the data that will inform us what is needed, because we can't fix what we can't measure. We need accurate data and not guesswork before proposing solid and meaningful legislation. And so this is why we feel this study is a good start on this. Our presentation we presented before Senate Commerce and Labor in February. Our champion is former Assemblywoman Sarah Peters, and we have a lengthy and robust presentation on the Nevada legislative website, and I encourage you to go look at that. Really gets into the meat of this. Our goal was just to kind of let you know what we're doing. But the SB 47 was passed in work session last week unanimously, with no questions, actually. We answered quite a few initially. And so now we're moving on. And as I said, right now we're working with the LCB Legislative Council on the amendment. For time's sake, if you have questions, you want to see the fuller presentation, please reach out to me, or you can go to the legislative website. But I'm happy to try and provide you, more information. As I said, Assemblywoman Peters has been our champion and our subject matter expert, and we so appreciate her efforts. So with that, I'm going to yield the floor back to the chair, the vice chair, And my next presenter.
Thank you so much, Miss Edwards. I am going to just hold questions until the end, if that's all right, for the sake of time. So
Yeah.
please write them down, committee members, and Ms. Haskin, over to you.
My apologies. I was looking for my unmute button. Thank you so much. I appreciate it. So this is going to be a delightfully brief overview of Senate Bill 68. Next slide, please. So there's two main components within this bill. The meat of the bill focuses on entering Nevada into the social work compact, which is an interstate licensure compact specifically for social work types. There's various types of licensure that would be affected there. It's not just one type or another, unlike some other compacts. The other piece of the bill would augment current language surrounding the types of information that different behavioral health occupational licensing entities would be reporting to not only the Interim Committee on Health and Human Services, as well as all of the regional behavioral health policy boards. Please, next slide. Let's start out with the Interstate Licensure Compact. So what would it do? It would enable licensed professionals who are in good standing in their home state to apply for an interstate license, in which they could then practice in Nevada if Nevada was a part of this compact. So it's kind of the best way to think of interstate licensure compacts is it would be the closest thing that you have to like a driver's license for professional licensure. I have a Nevada driver's license. I can go to California or Utah, no problem, because they're federally agreed to be the same nationwide. That's obviously not the case for our different provider types. How this could assist with our provider shortage is it would really expedite licensure processes for people who are wanting to either move into Nevada to provide services here, and it would also open up a broad spectrum of providers that would be available to Nevadans via telehealth, because then they could also access providers who have that interstate license or multi-state license in any of those states. Next slide, please. To illustrate what states could be then accessed for providers and vice versa. So the map that we have here was a screen grab that I did on at the last day of March. The states in dark blue are those that have already passed legislation to enter into the social work compact. The states in light blue have current or pending legislation to enter into the compact. So you can see the vast majority of states, by and large, would be entering into the compact itself. So if Nevada moved into the compact, again, that would really open the doors for a lot more providers via telehealth, and would also open the doors for a lot more potential clients for our providers that are already here in Nevada if they want to balance their caseload out with different types of clients. Next slide, please. So moving on to the data reporting. So current statute does mandate the reporting of certain types of data from the 4 primary behavioral health licensing boards. This is the Board of Psychological Examiners, the Marriage and Family Therapy and CPC Board, the Social Work Board, as well as the Drug and Alcohol Board. Next slide, please. The current requirements are really focused on specific numbers. So we wanted to, when we changed this language back in the 2021 legislative session, we wanted more information to illustrate what was going on at the different licensing boards. So we wanted numbers regarding the number of complaints received, the investigations completed, cases dismissed, cases settled, number of applications for new or renewed licenses, etc., just so that we could get a clearer picture of what was or was not happening at the licensing boards, since we were receiving so much conflicting information from stakeholders regarding the licensing boards not handling things appropriately, then talking to the licensing boards and saying, no, we absolutely are. So we were hoping to clear this up. Unfortunately, the reports that we've received in the last couple of years from the licensing boards have been wildly different board by board. And so this additional component to SB 68 would then ask for narrative descriptions of, okay, why are there any changes in the number or type of applications year over year? What are the primary reasons why applications are being denied, et cetera, which is stuff that provides context that we don't currently have. Next slide, please. So the reasons for those proposed changes are, first, go ahead and advance. Improve communication between the licensing boards, various entities in Nevada, including the regional behavioral health policy boards, as well as stakeholders as well. We want them to be able to tell their story and be able to clear up any misunderstanding what's going on. Second, improve consistency of reports. Like I said, there's 2 reporting bodies that have been giving us one line of information that has no real meaning or utility. And then there's 2 different licensing boards that have provided really good, meaningful reports as well, although both were very different. Next, advance, please. And then lastly, improving that understanding of how there are changes to the behavioral health system and recruitment are actually changing the volume of providers that we have here in Nevada. Because right now, just a set of numbers without any context doesn't really give us any information. Next slide, please. So mid-session status. So this was from, again, the last day in March that I sent this over. There's only one fiscal note that was submitted for SB 68, and it showed up to a 561,000 per biennia revenue. No actual losses. I've seen other interstate licensure compact bills that did have a fiscal note with a cost associated with it, but it was really a cost to Medicaid because there would be more providers available to fill the need, thus seeing more Medicaid patients. So that is something that, is kind of the balance with we increase providers and access to healthcare. We're going to see more costs associated to Medicaid as well. We were told, and by we, I mean my board chair, Fergus Loffridge, and I were told by Senator Pazina, who is the chair of Senate Commerce and Labor, where the bill was sent, that there were no plans on hearing any compact bills. And so as we sit right now, while the actual deadline is Friday, this bill is essentially dead as a doornail. This morning would have been the last opportunity to get an initial hearing and then a work session on Friday, and clearly that did not happen. We do not know exactly why. We were not told why this bill was not heard. We've heard lots of reasons, but as this is a public meeting and goes on record, I don't wish to entertain any of those because I don't want to get sued. However, there is concern about what may happen to interstate licensure compact bills that have moved forward on the Assembly side, and if they would be heard on the Senate side. It did not sound like it was our bill specifically that was an issue. It was more of an interstate licensure compact issue as a whole. So that being said, next slide, please. If anybody has any questions about this bill, please feel free to reach out either myself or our chair, Fergus Loffridge, and we'd be happy to field any other questions.
Thank you, Valerie. Next up, over to Mark.
Good afternoon, Mark Funkhauser here, Southern Regional Behavioral Health Policy Board. And the bill that is sponsored here is AB 31. It's on non-emergency secure behavioral health transportation. These are my disclosures. You can move on to the next slide. So basically, this bill increases the incentive paying providers both ways by adding the empty transport, or they used to call it unloaded miles. Medicaid's now calling it more empty transport for Medicaid reimbursements. In other words, right now the statute that exists does not pay for those empty transport miles, which so it only pays for transport when the patient is in the vehicle. So this would cover essentially the round trip, and that's part of this. The other part is a percentage increase overall for services, at least 15% rate of reimbursement for rural and frontier counties, and at least 10% for all other behavioral health transport services. So there would essentially be 2 components, paying for empty transport and also the extra percentage on incentives. So, and this behavioral health transport is different than medical transport, and obviously different than emergency medical EMS transport. Thank you. You can move to the next slide. Thank you. So currently the existing statutes are not fully utilized due to these low incentives, the inadequate reimbursement, and also restrictions on vehicles or other prohibiting factors. Law enforcement and EMS are the doorway to behavioral health care in Nevada right now. So this utilizing the behavioral health transport would free up law enforcement and EMS from having to do a lot of these transports. I was also in the fiscal note that Medicaid did for this bill. They noted that some medical transport may be providing that behavioral health transport in some cases. So there are serious gaps and barriers existing in rural and tribal regions due to limited transportation, long distances, and lack of available services. And then rural hospitals and jails are really not equipped with space, staffing, training, and they struggle with the long waits for patient inmate transfers. Next slide, please. So behavioral health transports cost, they burden local government, law enforcement, and EMS, takes them out of service and out of the region with increased overtime budgets and staffing needs. Also increased stressors, burnout, and turnover for overworked and underpaid professionals. Increased risk really whenever those personnel are out of the region. Say an ambulance has to go to Clark County or Washoe County to transport, that leaves the county at risk because they're not able to provide coverage often, and just makes a shortage in the existing area. So it really affects everyone in the state in that regard. Next slide, please. So AB 31 fills these gaps by reimbursing both ways and adding payment for empty transport. Also increases the reimbursement, gives an extra incentive for rural areas, and it's essentially an investment in adequate, equitable funding in Nevada by improving access to care and services, especially in rural, frontier, and tribal regions. Next slide, please. Thank you. Enhanced workforce is part of the solution. Improved services. It gets people to services that they often can't get on their own or without law enforcement or EMS transporting. It reduces local government burden and alleviates stresses on staff and scarce resources, and then enhances providers in crisis care while improving services for youth, children, families by providing greater access to services. And okay, and basically this slide here is just a summary, and in closing, I would like to say that this bill has had one, the Health and Human Services Committee hearing, and then it also had a works group that where it was moved to. It'll be moved to the full assembly. If it gets a hearing there, it will probably go to fiscal, which would be Ways and Means. So it's still with this potential fiscal cost and note on that, it's definitely running up against some resistance in the long run. There's lots of Medicaid bills this session, and as we all know, with some of the federal challenges and things like that, it's you know, there is some uncertainty about whether it will pass due to the fiscal note, but I would like to say it's definitely needed regardless. There's definitely a need for it, especially out into the rural and frontier areas. So, and then finally, my contact information, and you can go ahead and move to the, yeah. And then the board chair is Dr. Kevin Ossikarner. He's been one of the main advocates for this bill at the legislature, and also Assemblyman Gregory Hafen is on our board as well. So that's it. Thank you.
Thank you so much, Mr. Funkhauser. Over to you, Ms. Rawwood.
Thank you very much. Sherilyn Rawwood for the record. Thank you, Interim Vice Chair Johnson and SURG committee members for the space today to educate you all on AB 60. Next slide. That's just my disclaimer. What I say is not any reliance on what the board. Next slide. All right, so I'm going to start with why AB 60, and then I'll go into a little bit of the language. But certified professionalists within Nevada's coalition, or why AB 60 is important. First of all, it procures the substance use prevention, treatment, and recovery services. That SUPTR funding. SUPTR funding is hard to get if you don't have a CPS holding space in your coalition. You have to have that CPS within your coalition, within a place to get SUPTR's funding. It ensures that standardized qualifications and consistent or high of quality, making sure that they're evidence-based, they're best practice, and they're implemented correctly. It also establishes that certified prevention specialist, or CPS, as an official profession within state law. It also works on that framework for accountability. You know, you're hearing a lot of bills be heard this year, this session, and it's all about oversight or review power, or having that. And for our CPSs, it was really important for them to have that accountability, that review power, to make sure that the programs and the implementations of these evidence-based and best practice programs are implemented correctly. It also encourages the growth of a well-trained prevention workforce. I'm not kidding. To become a certified prevention specialist, it takes a lot of work. First of all, there's the class that you have to take, and then there's the 2,000 hours of prevention implementation that you have to be supervised to do, as well as some competencies. It also aligns these professions with broader public health objectives, such as reducing substance misuse, promoting mental health, harm reduction, things of that nature. It also ensures that efforts are grounded in law and regulations, giving them greater legitimacy. And then when we're looking at that return of investment, 31 billion saved in social costs from the Real Cost campaign, diverting 175,941 youth from becoming smokers. $1,196 saved in annual social costs per patient from hospital ED screenings. I could go on. There's tons of return on investment, and that's why it's really important that we look to codify our CPS. Next slide. Here's the language, at least the intro, the language that LCB put together. We're really looking to change NRS 433 by adding that definition of CPS. If you read this first little LCB kind of narrative, we looked at adding youth peer language, but as we were moving through that, we had some pushback from the community on what that was really going to look like. So as I started meeting with NCB board and ICNRC and things of that nature, we realized that we needed to remove that language this session and really focus on how maybe next session that could be implemented by making more robust trainings, looking at how long did they stay in that internship, what does that supervision really look like. So we had needed a little bit more conversation for that. So you'll see that there was an amendment, and that did pass to remove that youth language. But we did, our job really is to remove or to add that definition of certified prevention specialist. Next slide. So the changes to the NRS. So this is what it will say in section 1. A certified prevention specialist means a natural person who has the authority to supervise, review. We really use that term review as opposed to oversight, because we feel like it really is compassionate to work together. We know that certified preventionists can't implement all of it, but allowing them to review and work with other partners and community members implementing was important. And then it goes on, and or implement evidence-based programs, policies, practices. Those are the 3 Ps that ICNRC really focuses on as part of their competency work, as well as other cultural relevant initiatives into our interventions into schools or communities, prevent substance use disorder, and other behavioral health disorders, prevent early onset substance use, and reduce the harm caused by substance misuse, substance use disorder, and other behavioral health disorders, and then address those systemic barriers to wellness for the purpose of improving public health and reducing the frequency of substance misuse, substance use disorder, and other behavioral health disorders. So that's what the definition is that will be in section 1 when and if this bill goes through. Next slide. There's a secondary purpose as well for AB 60. Coalition work is driven by evidence-based programs and initiatives, ensuring they align with the best practices or evidence-based. We want to make sure that we're utilizing certified prevention specialists to review, making sure that we are implementing those to best practice or evidence-based. Regular review and consistency in prevention efforts help retain the effectiveness of evidence-based projects and programs. So going back and make sure that that review is done annually or biannually, and making sure that the programs that we are implementing are good. I talked about the 3 Ps of prevention, which is evidence-based practice, programs, policies to enhance community impact. The coalitions, once this bill passes, see, I'm thinking future, the NCB, as well as peers, community health workers, certified prevention specialists will come together, and we will write regulations and code for the work that they do to align with that definition that we are adding in section 1. As well as in 2024, Standard Occupational Policy Committee through the U.S. Bureau of Labor Statistics convened to work on adding substance use prevention specialists to 5 currently listed detailed occupations. So in section 21-1090, which is miscellaneous community and social service specialist, they added a certified prevention specialist as one of those. So we're aligning with also the federal guidelines and definition of the Occupational Policy Committee. As well as you just heard Don Yohe give millions of reasons why we need to make sure that certified preventionists are codified into law due to the Funds for Resilient Nevada goals. That's half of what they work on. So when you look at when we look at some of those initiatives that they're doing, it aligns completely with the Funds for Resilient Nevada goals. Next slide, please. It also allows our CPSs to really work within some statutes that have already been designed when it comes to prevention. When we look at NRS 388, that's our schools. That's the prevention section for our schools. They speak about prevention, but they really speak to the suicide piece and not really to other preventions. And so allowing and really giving carte blanche for our CPSs to make sure that the schools are implementing correct prevention is really important, as well as that peer mentoring, making sure that that peer mentoring piece is also implemented into our schools, as well as NRS 458 is the operation of the state plan for coalitions. So, relying our certified prevention specialists to make sure that they are doing the work of the state that's been set out for their state plan, as well as overseeing the SUD prevention coalitions. Where's our bill now? Our bill was amended. That amended was passed in our work session. And so our physical note has already been removed. They gave us a physical note of $3,400 for training SNAMs and NAMs employees. And I said, that's the wrong prevention. We don't need those people trained in this type of prevention. So they removed that. I was able to get that money removed. So we're just waiting to go on the floor and then be voted on into Senate. So fingers crossed, we have a few more days. Next slide. All right, my contact information. I did not put the chair of my board on there. Y'all know her, Shayla Holmes. She chairs the Northern Regional Behavioral Health Policy Board. So she sits on your board as well. So if you have any questions, you can ask her directly. But I hope I didn't miss anything, Chair. And with that, that is my presentation.
Thank you all so much for an excellent presentation on the multiple legislative bills coming out of the Behavioral Health Policy Board. We have time for 1 or maybe 2 questions, so would love to hear if the committee has any questions for any of the presenters under this agenda item. Debbie Nadler.
Yep, real quick question. Under the SB 47, does that have any language in it that pertains to mental health specialists in our school systems?
Great question. Was that Ms. Edwards?
Yes.
It was. It does not, Ms. Nadler, I don't have it all in front of me, but it does not have reference to that, but I will go and take that back to our legislative team, and I appreciate that. And if you have something you'd like to see, please be sure that you get that to me. But I appreciate that comment. That's the sort of thing we want to hear.
Thank you. I'm going to email you. I have some
Fabulous.
ideas. Okay, thank you
Fabulous.
so much.
No, thank you.
Excellent. We have a question here in Las Vegas from Dr. Dixon.
Yeah, Dr. Dixon, for the record, I want to make a comment on the rural region for Ms. Haskin. I think it's very unfortunate you weren't able to move this bill. And the medical board has been using an interstate compact for years, and it's made an incredible difference in getting doctors licensed and able to get into this state. And if you've got a similar bill in the assembly, maybe you might get one of the medical board people to talk on it.
For the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. Thank you so much. That would be, yeah, it's not our bill, but Assembly Bill 163, which was sponsored by Assemblyman Hafen, has passed out of committee, and that one would enter Nevada into the counseling compact for, in Nevada, they're called certified professional, or yeah, clinical professional counselors. So they're either CPCs or LCPCs, depending on what state you're talking about. So there is another opportunity. We just, I guess, need to hope for the best. I don't know if there is another interstate licensure compact bill that was in Senate Commerce and Labor along with ours. That was very healthcare focused from the Patient Protection Commission. That was SB 34. That also obviously did not go anywhere. So who knows what the outcome will be, but definitely if we can potentially get a hearing, that would be great. But unfortunately, letters of support and that sort of thing are not posted until a bill is agendized for a hearing. So while we know that there were many letters sent in for our bill, none of those were posted publicly.
Thank you. Any other questions for our presenters today? I did have one quick one, if appropriate. Jessica Johnson, for the record, for Ms. Haskin. I heard a question in community around, I'm not a social worker, but I know one of the core functions really is to understand like the macro, meso, and the interaction not only with the individual, but with the environment. And I'm curious, and I'm asking this specifically about social work for licensed professionals. In this compact, I know there's likely understanding the laws and cultural competencies. Are there other factors that you're aware of related to like understanding the resources and some of the like experience of that individual interacting with their environment that might be specific to social work? I've just looking at your map, I can imagine those resources being different between states like Washington State and Utah and other areas. So I was just curious if you had any comments on that.
For the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. Thank you so much, Jessica. So the way that all these things play out is the benefit to licensed social workers and licensed master social workers, who are not behavioral health providers. Really, the benefit of the compact would be if they decided to move to Nevada and practice physically in Nevada. I could foresee a huge benefit there. Things like regular social work and case management is very difficult. I mean, even if somebody tried to be a case manager for someone in Elko and they were located in Las Vegas or even in Winnemucca, that could be very tricky regarding, the differences in resources and how to navigate that. That's really a service that should be provided within the community itself. There are a lot of bills right now that do propose extended use of social workers, and particularly school social workers, which a school social worker would have to be a licensed social worker through the Nevada Board of Social Workers and then get an endorsement through the Nevada Commission on Educational Professional Standards, I think is what it's called. So it's kind of like a two-part process for them. So it could expedite that if someone was moving to Las Vegas or Reno or Elko or Yerington or wherever else to be a social worker of any type. As far as the LCSWs, who are the providers, that's more of like a one-on-one counseling type. And so that would be more appropriate for telebehavioral health type of modalities if that person lived outside of Nevada and provided care to the individual. LCSWs are very well poised also to be really fantastic clinicians to add to mobile crisis response teams because they do have an understanding of those multiple layers, the social determinants of health, and a lot of that's their focus. And so we're very disappointed with this outcome, but hopefully we'll be able to see something else next session.
Thank you. Thank you to the presenters on the behavioral health policy boards and current legislation, and I appreciate the questions from the committee. Not seeing any additional hands raised, I'm going to go ahead and move on to the next agenda item number 9.
Of the coordinator.
Thank you. This is a legislative update. Dr. Terry Kearns and Laura Hale, turn the floor over to you.
Thank you, Vice Chair. I appreciate that. Terry Kearns for the record. I just wanted to highlight a couple of items under this. And the first one is just to highlight that there will likely be cuts to Medicare. And obviously that's something that's being looked at the state level right now. And also COVID era funding to state and local health departments has already been pulled back. So that will affect a lot of what's being looked at from the budget standpoint. And I also, this isn't our legislation, but I wanted to highlight that I received information from the Office of National Drug Control Policy, ONDCP, that did provide guidance from the White House on their priorities for substance use. There were 6 priorities. I'll just read those 6 ones real briefly. And I have the report. If anybody would like a copy of that, I'm happy to send that out. Number 1 is to reduce the number of overdose fatalities with a focus on fentanyl. 2, secure global supply chain against drug trafficking. 3, stop the flow of drugs across our borders and into our communities. 4, prevent drug use before it starts. 5, provide treatment that leads to long-term recovery. And 6, innovate in research and data to support drug control strategies. So that's just out there. And I think in lieu of time, we have provided a handout with all of the bills that we're looking at, and those can be looked at to get an update, but we're not going to go through those specifically today in lieu of time. Laura, do you have anything you'd like to add?
Oh, Laura, if you're talking, you're on mute.
I think Laura's indicating she doesn't have anything
Okay.
to say and cannot get the
mic to
console and Carson. to
Okay,
unmute.
wonderful. Thank you. Glad Kelly can read lips on Zoom. So thank you both so much for that update. I really appreciate it. With that, we're going to move on to agenda item number 10, which are the results of the annual SURG member survey. I'm going to turn it over to Crystal Duarte.
Thank you. I'm going to make this brief as well. So you can skip to the next slide. This is a survey we do every year. And we put it out in February and January, to cover the period of February 2024 through January 2025 to find out what worked really well for our committee members and what we could improve on. And you can go to the next slide. This year we had 10 responses out of 18. And we have the complete responses on each of the following slides. And basically we had some general comments that things worked really well, that the meetings, there was a lot of meeting preparation and organization, having the meeting scheduled out early helps. And then on the subcommittee realm, things work really well when there's a pre-meeting with the chair and having the agendas in advance. The recommendations process, which you will remember we changed last year. We went from ranking recommendations at the subcommittee level rather than as a whole. That seemed to work for everybody, most people, or at least those that responded to the survey. And there was one other comment on here. I'll just keep going, Kim, to question 2. So anything that could be improved, and this meeting may feel that way too, is that it might be too organized, preventing some open discussion among committee members on specific pre-chosen topics. So sometimes we're packing a lot in, I think, like we are today.
Yes.
And then On question 3 is about annual report distribution, which Dr. Kearns is going to go into next, but people had additional suggestions for sharing, which was with the Nevada state legislators, which is part of the legislation for the SURG as anyway, so it goes to that group. Legislative committees and the Behavioral Health Association of Nevada. I believe it was our member Christine Payson that shared it with the Nevada Sheriffs and Chiefs Association. So there's where our reporting has gone, or the last year's report. And then additional comments. There was one comment about a money chart showing a breakdown of exactly where the money has been distributed. And so that was something that we were hoping would help with today's overview of the dashboard and the Fund for Resilient Nevada report. But those are the results of the annual member survey.
Wonderful. Thank you so much for sharing the survey results. Any questions related to the annual SURG member survey? All right, seeing no one immediately hop off of mute, we'll go ahead and move on to agenda item number 12, which is an update on annual report dissemination. How timely. Dr. Kearns, the floor is yours.
Thank you. Terry Kearns for the record. As outlined in AB 374, which is now NRS 458.460, the report was distributed to the governor's office and then to LCB for all of the legislators, also to the Department of Health and Human Services Director, but also then we pushed it to Department of Public and Behavioral Health and the Fund for Resilient Nevada within DHHS. And then also to Steve Yeager, for the Commission on Administration on Justice. And each of the regional behavioral health coordinators received a copy of it, as well as the prevention coalitions received a copy of it. And then the Attorney General's office did do a press release with the annual report, and that was pushed out.
Wonderful. Thank you for that update. Any questions for Dr. Kearns on the dissemination of the annual report? All right, seeing no one immediately hop off of mute, that moves us to agenda item number 14. I think, if I'm calculating correctly, which is our final period of public comment. If we can move to, is there a next slide with details? Yeah. Wonderful. And if someone from the SEI team wouldn't mind, if there's any additional details that need to be read related to public comment.
Yes, so public comment, this is Kelly Marshall for the record, will be limited to 3 minutes per person. We're going to begin public comment in Las Vegas and then go to Carson City and then take it virtually. We would ask, please go to the next slide. If you're dialing in from a telephone, please dial 719-359-4580. When prompted, enter the webinar ID 84116156-896 and the meeting passcode, which is 676835. And you can press *6 so that we can prompt the host to unmute you. And so I see Ms. Wood has her hand raised.
Wonderful. We'll open it for public comment. Sherilyn Wood, the floor is yours, Ms. Wood.
Yeah, Sherilyn Roy Wood for the record. I'm not sure why that came up, Sherilyn Wood. Quick question, Dr. Kearns, you had spoken to a sheet you have for the bills that you guys are watching. I was wondering if you could share that, or is that going to be on DPPH or on your website? However, I can pull that up. I'd love to see it.
It is on the Attorney General's SURG website for under today's meeting.
Perfect.
If you need the address for that, just send me an email. I'll get it to you.
All right. Thank you.
Thank you. And sorry, I didn't follow the rules. Anyone in Las Vegas for public comment? Mr. Mandel?
Giuseppe Mandel, Optima Healing and Recovery for the record. Thank you guys all very much. I greatly appreciate all yours comment and everything that I've learned today. I just wanted to highlight just a couple things real quick, I just wanted to highlight a couple things just to sponge any myths. You know, I'm a person of lived experience myself, and I can tell you that one thing that would deter me from treatment is not necessarily a couple more hours of overdose or a couple more hours of withdrawal. What deters from treatment is the lack of access to get into treatment and the lack of funding and budget to be able to access treatment while going through withdrawals when you have that moment of clarity. You guys are all working very hard at trying to address that issue, and I thank you for it. And Dr. Wagner, I'd love to collaborate with you off the record on one time to just talk about some of the data, because us in the field, we are seeing that stimulants and stimulant users that are coming into treatment are testing positive for fentanyl and opiates unknowingly. And a lot of the ODs that I've experienced, even as of late, including my own brother 3 years ago, it was not knowingly in a stimulant substance. So, I mean, granted, I appreciate all the hard work and the great way that you presented it, but I'd love to collaborate on where some of that data is coming from, because our data on the ground level is a little bit different. So, and thank you guys all very much, and I look forward to the next meeting. Thank you.
Thank you. Any additional public comment in Las Vegas? Any public comment in Carson City? All right, seeing none, and any additional public comment online? Please feel free to raise your hand as Ms. Marshall walked us through. Seeing and hearing none, I'm going to go ahead and close agenda item number 14, public comment, and we'll move us to agenda item 15, which is adjournment. Thank you all, SURG committee members, for your hard work, and a big thank you to the SEI team for keeping us organized and on track and preparing all of this work in advance. Really grateful to do this work with all of you statewide. I wish you the best rest of your Wednesday. Take care, everyone. Thank you.
Thank you.
Thanks, everyone.